All right, I'm going to go ahead and call to order our Quality and Patient Safety Committee meeting this Thursday, July 24th.
Dorothy wants to hear the gavel.
Oh. We're called to order officially now. So I thank everybody for coming and joining us today. And to our new board member, thank you for joining us. You'll learn to love quality. There are, as I understand, no citizens wishing to address the committee today. And so we will continue on to approval of the minutes from our last committee meeting, which was April the 24th. Could I have a motion to approve? Thank you, Dorothy. Second. And a second by Dr. Casey. So we will approve those minutes. And then we're going to go ahead and start with our patient voice from Dr. Badamosi. We do this for our new committee member. We do this just to kind of center us in the meeting and just kind of reaffirm why we are here and what our mission is, the true north, which is our patients. So thank you, Dr. Badamosi.
Good afternoon. The patient story today is 90 seconds, but very, very impactful. And this is really what we hope for. And as you'll be learning today, we'll be bringing to you the processes and the people that underlie these results that we're seeing, and why we're very, very optimistic that this will be the story we'll be telling moving forward. Patients, yes. While they help us tee up our slides, this story is, go back.
Go back.
There it is, right there.
This story is that of one of JPS patients that actually went to an external facility with a cough, but left with a diagnosis of metastatic lung cancer with brain involvement. And one of the most impressive aspects of this story is this happened over 6 years ago. Yeah, so.
The main doctor that took care of me over there told me, go to JPS. They have a good cancer clinic, and you'll get the treatment that you need. But to be honest, I don't think in his mind he thought I would have survived it either. And I did. And my daughter came down and got the dog. My name is Kimberly Williams. And I'm here to tell you I beat stage 4 lung, brain, and bone cancer.
Like the CT came back good.
I do that in December. Oh,
The CT scan.
I read the, on my chart it did.
Yeah.
I just want to hear your opinion.
Yeah.
So today when she told me I didn't have to come back every 6 months anymore, I was a little nervous. Because she's been my safe place, I felt like, with the news. I get the news, or my scans before she does, and I see them, but I feel more comfortable it coming out of her mouth to me that I'm okay.
You beat the odds, so it's fine.
I know. I told you I was going to beat it. It has made me realize, don't take life for granted. I just had to keep telling myself that I was going to beat it. I didn't think I was going to, but I did. Just don't take life for granted.
That really is a very powerful video, and it's really a testimony to what is possible. And that story was not possible a few years ago. But we are so glad that we're making that possible, and our expectation and hope is this is what we'll continue to see. It's my pleasure to actually invite my team members and colleagues that have been doing the work. Full disclosure, I'm a pulmonologist. That is my trade. I'm really very passionate about this stuff, but there are people that have actually been leading the fight, doing the work. First, I'll call Dr. Paras Patel. Fun fact about Dr. Patel, he's also a pulmonologist, but he was a pharmacist. He's a PharmD, then went to medical school. He's boarded in internal medicine, pulmonary medicine, critical care medicine, sleep medicine, and interventional pulmonary. He's our interventional pulmonologist, and he does procedures that nobody else can do in this county. So it's really a distinct privilege to get to work with him every day all through these years. Please, Dr. Patel.
Thank you, Dr.
Then Dr. Nara, the most important and fun thing to remember about Dr. Nara is everybody that have come across her, the question they always ask is, how do you find time to do this? She is an oncologist, boarded in both hematology and oncology. She is at a cancer center. She's very, very well published. She is very tenacious. She follows through and has done tremendous amount of work. Our patients love her. We brought a lot of video here that featured Dr. Nara. It's just a testament to her hard working and commitment to JPS. Next is Raymond Johnson. He's our radiology quality manager. I've been working with Raymond since I came to this organization, and very impactful, and has done tremendous amount of work with lung cancer and other cancer, and just overall quality. If I need something done in radiology or some information, Raymond is my go-to person, and he's just has been a fantastic partner through this journey. I will turn it over to Dr. Patel, Dr. Nara, and Raymond.
Good afternoon, everybody.
Yeah, you could.
Good afternoon, everybody. Thank you, Dr. Balamusi, for the introduction. So today we are going to talk about our unique program here at JPS, which is the lung nodule lung cancer. The reason I say unique is because we, from radiology, oncology, interventional pulmonology have come together to, with this task of how to treat effectively lung cancer, how to reduce the time from diagnosis and treat these patients more effectively and the best we can. So I will start off with the first slide, a little bit about statistics. Imagine a Boeing airplane with 433 seats. Now consider this: if this airplane had an accident today, it would undoubtedly make headlines in bold letters. All the news channels will be featuring this for days, weeks, months even. But if you look at lung cancer, it claims lives of about 350 individuals every day. Still, we don't talk about it that much. A little more about statistics. On the top column, you'll see estimated new cases in both males and females. In males, the number one new case is of prostate cancer, which is 29%. And on the right-hand side, in females, it's the breast cancer. Number second cancer is lung and bronchus, same in males and females. But on the bottom column, you'll see the number one estimated death, the number one cause of death from cancer-related, both in males and female, is lung cancer. And so whenever we talk about any type of cancer, we talk about screening. How can we identify these patients early so we can treat them effectively? We have an excellent screening tool for cervical cancer. We screen about 75 to 80% of these patients. We have a good, robust screening tool for cervical cancer, for breast cancer, mammogram, for colorectal cancer. We do colonoscopy. On the bottom, you will see lung cancer. We only screen about 5% of eligible patients. This is nationwide, as compared to cervical breast cancer, which is about 75-80%, and colorectal is about 70%. But here at JPS, we are screening 25%. 25% was before up until 2024. In 2024, we screened about 46% of eligible patients. So we are doing much better as compared to nationally.
6%.
So nationally, pulmonary nodules are present in approximately 20% of all CT scans that are done at any institution. And at JPS, we perform about 30,000 CT scans. So 20% is about 6,000 patients have some form of lung nodules. So these patients, as soon as you tell them that you have lung nodule, you have a spot in your lung, a lot of, they have anxiety build up, they are stressed. And so we want to help all these patients through the journey and make sure we take care of them quickly and effectively. The good part is about 95% of these lung nodules will turn out to be benign, not cancerous, which is a good sign. And up to 71% of pulmonary nodules, do not receive the recommended follow-up. Most of the time when the CT scan is read by a radiologist, they mention that, follow-up CT in 3 months, 6 months, 9 months, but about 70% of them do not follow through because of some or the other issue. And the worst part is there is no set guidelines or recommended standards for referral practice. Once you find a lung nodule, what does the referral process look like? So here at JPS, we have streamlined every single thing so we don't miss not a single patient. And so these are the recommended screening guidelines for lung cancer. Patient who is between the ages of 50 to 80, who has smoked for greater than or equal to 20 pack years. The pack year they calculate as if somebody has smoked 1 pack of cigarette a day for 20 years is 20 pack. Same thing as if somebody smoked half a pack for 40 years is still 20 pack, or 2 packs for 10 years is still 20 packs. And if they are current smokers or who have quit within last 15 years, and they are asymptomatic, they are eligible for this low-dose screening CT chest. As compared to colonoscopy for colorectal cancer, it's much more invasive. Any form of other prostate screening or anything, you have to draw blood work or anything. Here it's completely non-invasive. It takes just 5 minutes of your time to get a CT scan. You just go in the tunnel, come out, and here we can find out if you have a spot or not. And the other important slide I have here is the number needed to treat. This is how many people we need to screen to save 1 life. On the top column you'll see is low-dose screening CT for lung cancer. All you need is 320 patients screened to save 1 life. As compared to mammogram is 377, colonoscopy is 871, and HPV testing is 2100. So this is very low-hanging fruit that you can screen these patients to save a lot of lives. And next I'll talk about is staging and survival in the United States. In lung cancer, non-small cell lung cancer, we have stages 1, 2, 3, and 4. Stage 4 being the most advanced stage. And you will see nationally, stage 1 is diagnosed in about 23% of patients. Stage 2 and 3 in 21%, and stage 4 is in 52% of patients at the time of diagnosis, when there's so much advanced. And the other reason is also people don't undergo screening, and second is in lung cancer, most of them are asymptomatic. They have no symptoms at all, and that's why it goes undetected. Of 50% or more of those stage 4 go untreated because they are deemed to be, advanced stage, and they don't undergo any treatment. On the right-hand side, the slide shows the 5-year relative survival. If you are diagnosed with the cancer, what is the chance that you will survive 5 years? If you are at stage 1, which is localized, you have a chance of 64.7% that you will survive 5 years. As compared to distant, which is stage 4, you have a 9.7, less than 10% chance that you will survive 5 years. So the 5-year survival for lung cancer is extremely, extremely poor. So we want to identify this patient very early. Increase in early detection of lung cancer where they are in the form of small nodules, that's the key we want to do. And diagnose and treat in a timely manner, including treating as many stage 4 patients as possible. Next, I will hand over to Raymond.
Hello, everyone. Thank you for having us here. Very, very glad to be here today. Kind of one of the things I just give a little background. I got into radiology in the quality role and was handed on lung cancer screening back in 2018. And very exciting program at the time. It was originated in 2016, and I got invited to present to the oncology clinic in 2019 about the results and some of the things that we had been able to do. And so we were actually able to increase our stage 1s from 2018, had a percentage of 19% that were coming across, and we actually moved that needle up to 26%. And so we're really, really proud of that. And at that meeting, Dr. Duncan was sitting in the front row, and I love telling this story because it really was my inspiration. And she asked me, what about the rest of the nodules that come across, Raymond? And at that time, I was so focused on lung cancer screening and so proud of it, I hadn't looked at that. And so I did look into that, and like Dr. Patel said, 20% of every CT of the chest that comes across has a pulmonary nodule finding. Last year we did about 1,700 lung cancer screenings here, but 30,000 chest CTs, right? So we're looking at a larger volume. We're looking at 6,000 nodules that are coming across, and how are these being managed? And we had such a great program with lung cancer screening, we decided that how about we duplicate that? How do we do that, though? And so we met with some artificial intelligence vendors, and we came across natural language processing. And what this does is it actually goes into every radiology report, it pulls the findings, and then shows them to a navigator, such as myself, right? So instead of me reading 30,000 reports looking for 6,000 nodules, it actually brings those 6,000 nodules to my attention, and then I'm able to look at them, right? Then from there, I don't know if I want to read 6,000 reports either, right? And so I sat down with Dr. Patel, and I said, Dr. Patel, what are the patients that you want to see? What are the nodules that you want in your clinic? And so we looked at the guidelines, we reviewed those numbers, and we said 8 millimeters and above, Raymond. Those are the ones that I want, right? And how do I get those to you? How do I tell you the importance of a nodule, or how do I screen the ones that aren't so important? So again, going back to the lung cancer screening, it uses a scoring system, 1, 2, 3, 4A, and 4B. Very, very simple. It's a great way to communicate findings too. So instead of going up and trying to identify this is an 8 millimeter nodule located in the upper lobe and it's spiculated, I can just say that's a 4A, right? Very easy to communicate. It's also very great for our providers because they know if it meets a certain threshold, they have actions to take. And if it's not at that threshold, they'll just follow up with their patients. So we rebuilt it. And you can see on the screen here is that we rebuilt that and mimicked the lung cancer screening program and aligned the referrals to match that. So anything that's a 4A or 4B gets referred to pulmonary. By using the AI and using the natural language processing, I'm able to filter those nodules, and then I send them directly to the pulmonary nodule manager or clinic, which is Dr. Patel's right-hand man, in this case, right-hand woman. And she actually looks these patients up, validates whether or not they have a referral, or asks to get a referral to get them in clinic as soon as possible. The 4A and 4B, it also triages those patients for Dr. Patel based on risk. So he knows that that 4B has to get in the clinic sooner than maybe that 4A does, right? And get more attention. So we've been doing this program for about a year now. It's been very, very, very successful. And one of the things that we were able to do is we did a 6-month analysis of before we implemented this and after, and solely based on our referrals. How many referrals were we able to get? Were we able to increase that? Our 4Bs, 6 months prior, we were about 78% of those patients were getting referrals to pulmonary. 4Bs now are at 92%. We don't miss very many of them. And if we do, we know why we missed it, or why the patient didn't come back, or what the situation was. And so it's a great way to see that. It's also a great way to see the clientele, how many of these nodules are coming in at these sizes, and are we getting any early detection. Our future plans are to really focus in on those 2s and 3s. These are your smaller nodules, maybe not ready for Dr. Patel and intervention, but they do have follow-up that's important to make sure that they're not growing. And we're all about early detection, and because of that, if we can catch them when they're small, we can hopefully find them isolated and get more stage 1s. I don't know how to, this guy? There's no standard on the referral practices. So they have standards on all the recommendations in radiology and thoracic surgery. So they're able to put recommendations in, but when do we say, I want this to go to Dr. Patel? When do we say, I want Dr. Badamosi to see this patient? It's all up to the primary care physician or the physician caring for them, right? So essentially, I could send every nodule to Dr. Patel, right? And when I actually first met Dr. Patel and I said, hey, what nodules do you want? His answer was all of it. And we laugh because now you know there's 6,000 of them. And
He can see 1,200. Yeah, he said he can see 1,200 a year.
so it's one of those things that you have to evaluate clinical capacity and staffing and what you can and can't do. And at the same time, what are you going to do with this patient? And if you're going to follow them to the term. So that's one of the things that really is defining the referral technique, who we're going to refer, and then who we're going to send back for management with their PCP. Yeah. So let me go back. That's a great question. With these scoring systems, that protocol is based on the recommendation on the follow-up that's associated with that size of nodule or type of nodule. So when we look at like a 2 or a 3, those are follow-ups that are 6 months or greater. So 3 is a 6-month to 12-month, and a 2 is a 12-month or 2-year follow-up. So we look at those based on risk stratification, on the possibility of those being cancerous versus benign. And then when we look at the 4A and 4B, those are 8 millimeters or 15 millimeters, which have a much higher risk of potentially being cancer. And so we want to make sure that we follow up on those as soon as possible and get those referrals. So again, this is, the guidelines do have all of the recommendations that are supposed to be in the radiology reports. But when it comes to process management, referral practices, there's not really a whole lot of publications on saying how to do this. And so that's one thing that we wanted to do here.
Yeah, right now that the nodule classification
So
is manually done,
yeah.
but in the future you're going to get the
Yeah.
AI to do it.
And so that's essentially what we're testing right now, is part of the AI, there's 2 levels to it, And the first level is the natural language processing, which is pulling the finding. And then we've built the algorithm out. And so that algorithm uses the finding from the NLP and then automates a score, which we validate. And so essentially that algorithm and that structure is reproducible. And so when we look at lung cancer screening is extremely structured. It's relative to mammo and those kinds of things. And you must, as a CMS requirement, use the scoring system in lung cancer screening. The outcomes, the recommendations are standardized. And because they're standardized and regulated, then it's much more controllable. And then it's also, it allows for different computer systems to analyze same phrases or structured reports, right? And so the goal here is, yes, it is something that we're working on and getting to the level of a structured report, getting to the level of radiologist buy-in so that they would put it in their report. I speak to our group here, the Radiology Associates of North Texas. They've helped me build this to show and make sure it reflected what they were communicating with patients. And so getting those, or getting to that level of having a structured report, so it would be very crossover into Epic, into patient charts, and then at the same time, communicated to anyone that's ordering those chest CTs.
I have a question. I know that for mammograms, insurance is gonna notify me, I go every year. Colonoscopy, they have something that's covered, but for screening for lung cancer, my sister, 2 years older than I, died from lung cancer. Now, she smoked, I've never smoked. But I wouldn't know that I need to have this lung cancer screening, so how does that tie in? Because one of the deals is that if I'm, I can always ask my doctor to send me to get a CT. She looked at me and I said, well, I don't think so. And then by instead, she said, okay, you can pay your $250 and whatever your copay to do it. But I don't know as a patient when I should be screened.
Yeah.
And you go to the doctor, they do that, and physical is never mentioned. So.
That's something that we have implemented here. We have something that's called a best practice advisory. So that best practice advisory is programmed to go through each patient's chart. So if you were to go in for a physical, all right, and you met the requirements for a lung cancer screening, this BPA would fire to your physician telling them that you are eligible for a lung cancer screening, right? And that's good, that's a conversation starter to go through, hey, what is your smoking history? What is the situation? Have we talked about maybe potentially quit smoking? And now I have this program, lung cancer screening, that I think you would benefit from.
What about the people or the patients who's not going to make that first doctor's appointment? Where does the outreach come in to even let them know, hey, you need to be, how are you doing an outreach effort, or that, whatever they call it, like the National Kidney Foundation usually go to these different locations throughout, these communities that test for diabetes and, high blood pressure and all these things. Or have you guys considered like put an outreach for this?
We did have an event in November in which we did have that, where we hosted it and we tried to make it known, like, hey, these are the requirements, this is a program. There is the Lung Cancer National Awareness Month, and it is the white ribbon in November. And so we're trying to promote those kinds of things, the white ribbon, because
Yeah, it's not as back, October is Breast Cancer Awareness Month, everybody knows it.
Everybody knows Pink Ribbon.
Komen Foundation, everybody knows it, but November is lung cancer, nobody.
Right, so, okay. May, the hills.
I want to kind of reiterate Dorothy's question. Obviously, I have a primary care bent, and these patients are notoriously hard to find, right? To document, to pack your history is really hard, right? Especially if they've quit, because the MA who's doing the intake says, are you smoking? They say no, and they just say no, they are not smoking. And so to go to your question, it is a very hard patient population to find. And so I love that you're running the nodules of the existing CTs, because I have a feeling you're going to identify a lot more patients in that way. But yeah, I'd love to know what y'all have done to get the primary care on board to help screen for patients.
I think what was remarkable about this is that when we speak about and what insurance approves as preventative testing, lung cancer is not one of those.
Yeah.
Okay, so it doesn't come up on the preventative screen for the primary care doctor to screen for it and send it for CT yet. As Dr. Patel said here, it is low cost, it's not invasive at all. You're losing over 300 people a day to lung cancer. And I think it's more around the advocacy, and I think this is the work that is going to really set it from a national standpoint to get the conversation to a point that just like you are told to go get your mammogram done or your colonoscopy done, you're also going to be told to go get a CT scan done so that we can identify and improve the quality and quantity of life for our community. So I think this is what's amazing is that this work that's being done at this level with a very collaborative, multidisciplinary team, to me is what is just, I mean, I'm just so impressed by, and I'm like, I've got to get to Senator Kennedy and tell him that he can get a good stamp by just bringing this up to a preventative test, so.
Yeah, so Dr. David Gerber, he is one of the medical oncologists. He's heavily involved in the screening program at Parkland and UT Southwestern. And so we have collaborations with them on the, like the protocol that we wrote for like getting all the project together was using some of their templates about how they're integrating it. So, but we don't have like a formal collaboration, but we do have a collaboration through CPRIT in the clinical trials department, but he is a thoracic oncologist and he has done a lot of work. So we had conversations with one of his associates for a few months last year. But I think our program is more robust with both the screening. We're not just having screening, we are doing the every lung nodule. I don't think that part they have.
So, and more importantly, there's been a lot of conversation at the leadership level about our outreach programs and how we get better into the community in terms of all of these lung cancer, hypertension, diabetes, smoking cessation, and counseling to ensure that we actually reach all of our communities that need to be aware of this information and risk and what we need to do. And beyond that, we're also putting in place with our outreach team how we're going to define success. What will be the parameters that we'll have in place if we go to a particular community and perform outreach? How are we going to say, in this group, our outreach is working? So we're actually collaborating a multidisciplinary team at the leadership level to actually do more of that. There's a lot going on, but to your specific question, this is a major area of conversation, and we'll definitely be bringing back those reports to you.
Mm-hmm. Yeah, sure, that would be great.
Absolutely. That's a great idea.
Yeah.
All right. And this is just kind of an overall of how our process works and really what that looks like and how we communicate that across. Is so we do have the lung cancer screening coming in on imaging, also lung nodule found on CT. That comes to the radiology navigator, and currently that's myself. And so I'll triage or I'll score these patients and then send those 4As and 4Bs on to Dr. Patel and his team. He'll triage them, whether or not he wants to take them to the interventional pulmonary nodule clinic or just to the nodule clinic, where they'll monitor it and take appropriate steps. And end result is it resolves itself, we identify it as benign, or we have to take additional measures. And I'm going to pass off to Dr. Nara.
Dr. Patel, he's going to talk.
So going back one slide, so what happens is that Raymond sends all the CT scans that have identified as there is a potential lung nodule to us. And then we have a navigator who screens through all the CT scans and identifies. We go through them and say, yes, this patient is at high risk for malignancy based on smoking history, based on the size of the lung nodule, based on the location, based on if it is speculated, appearance and everything. If we feel that, yes, this patient is at an extremely high risk, we bring them to interventional pulmonary clinic. If the nodule is present, but they are low risk, then they go to our lung nodule clinic where they get continued surveillance with CT scans every 3 months, 6 months, 9 months, or a year. This journey looks pretty long on the paper, but from identifying abnormal CT scan to us taking for an advanced procedure like bronchoscopy, the days, 14 days is our average. National time is about 35 days. So we have much reduced time. And also I want to take, opportunity here to talk about our advanced bronchoscopy procedure, which we have the ion robotic navigational bronchoscopy. I want to thank Dr. Duncan for getting us the robotic bronchoscopy, which is, we got about 2.5 years ago. The advantage to this, I will show you in the next slide, is we are able to reach peripheral and much smaller lung nodules. Before these patients used to wait, we used to say, hey, you know what, yes, you have a lung nodule, it is worrisome, but it is small, so we'll get another CT in 3 months. And then we wait till it grows for us to go do biopsy, but now we can do it even while it's smaller. It's much advanced in technology. And once we find that this patient has lung cancer, we diagnose them, then the referral goes to medical oncology, radiation oncology, cardiothoracic surgery, based on their age, their risk factors, which treatment options would be the best for them. So once we diagnose, then Dr. Gavach, Dr. Nara's team takes over from that point onwards. Going back to the lung nodule, once we identify, Raymond's team sends us a lung nodule. If the patient doesn't have a referral to the pulmonary clinic, we have spoken to our primary care colleagues here so that our navigator will reach out to the primary care, say, hey, your patient had an abnormal CT, can you place a referral to us? And we'll be happy to see. Even to our ER colleagues, because they order CT scan when they came in an emergency, they put all the lung nodule referral to our pulmonary clinic, so we take care of them. And here is our data on robotic bronchoscopy. We have achieved full diagnosis on first procedure in 85 out of 100 patients. as compared to older technology that we were biopsying, we were able to reach first-time diagnosis in only 60% of the time. Here now we are up to 85%. Many patients needed multiple procedure, 2, 3, 4 to achieve a diagnosis. Now we have not had to do that much on a repeat procedure. And
Okay, so far we've been talking about the screening and the lung nodules, but what is the impact that we are seeing in terms of the outcomes? So before we started the screening program, so JPS in 2018, we had stage 1 19%, stage 4 57%, and almost 50% of them of stage 4 were not receiving treatments. Then with what Raymond told about the lung nodule program screening as well as the robotic bronchoscopy, we have been able to get, this is from 2024, 27%, we increased it to 27%, and you can see the national level is 29%, we're close there. And stage 4, we've actually gone down 36%. And the patients within stage 4 who did not receive treatment, we were able to go down to 29%. So this is in the last 5 years. And you have to include that 3 out of those 5 years we had COVID. So, things, but still we were able to make this impact. Oh, sorry, I don't know what I did.
Way to finish it.
While Dr. Barmosi is bringing that up, I am a medical oncologist. I belong to the Oncology and Infusion Center, and we want to talk about the excellence in standard of care. So for patients with early stage lung cancer, we provide multidisciplinary approach. So early stage, like stage 1, patients can get either surgery or radiation, specifically stereotactic radiation treatment for stage 1. And we have multidisciplinary approach for stage 2 and stage 3, including neoadjuvant chemotherapy followed by, or immunotherapy followed by surgery or chemoradiation. For some stage 4 patients with immunotherapy are living over 5 years. We have seen the story, we have heard the story of my patient, Kimberly Williams. She was diagnosed in 2019 with stage 4 lung cancer, which went to the brain and the bone, and she has been living cancer-free for a number of years now. And that's just one patient story. I have several of those patient stories, and my colleagues also have. So next slide. Okay. So, and Mr. Wynn mentioned about Vietnamese patients or Vietnamese patients with lung cancer. Yes, 20% of non-small cell lung cancers occur in patients who do not smoke, and that is an unmet need in terms of screening because we don't know how to screen. And this is, and those patients who didn't smoke and develop lung cancer, they have a higher chance of finding mutations. So EGFR mutations are one of the common ones that are found in the Vietnamese and Southeast Asian population. And we have targeted therapy for them. Of course, we have to do this testing called next-gen sequencing on the tumor to identify those mutations. If we don't do that testing, then we are going to treat them with chemotherapy. However, if we are able to identify those patients' mutations, 80% of them respond to tablet treatments. And with EGFR now, the median survival is close to 4 years. But with ALK, which is another targeted mutation, median survival with stage 4 lung cancer ALK mutation is 8 years. So identifying these are important, and we have the next-gen sequencing on tumor to identify these patients. Other thing is patients with any stage of cancer or stage 4 with brain mets, we have a stereotactic radiosurgery approach to treat those patients. So even if they're stage 4, they get, instead of whole brain radiation, they can get these local approaches. You go one more slide. Then, yeah, we are, as I showed, we are excellent in standard of care. Now, what are we doing more for our patients that is beyond the standard of care? So this is what we are offering. Within the last few months, we have 4 lung cancer clinical trials with novel therapeutic agents, we are making the new standard of care for the future. We are trailblazers. So one of these 2, we are one of the 2 sites in Texas, other than MD Anderson, for the trial called Crescendo trial, and we had a patient referred last month from UT Southwestern. They don't offer this trial, we offer, so they refer a patient here. Crescendo is Roche Genentech trial. Then we are the only site in DFW area for Artemide trials by AstraZeneca, Artemide Lung 2 and 3, and we just enrolled a patient about 2 weeks ago. And we enrolled first patient nationwide in a prospective non-interventional study for the EGFR mutation that I talked about. That's in nationwide, we enrolled first patient. Then we, whatever you have discussed from Raymond, Dr. Patel, and other outcome studies, my students presented 10 posters at national conferences in the last 2 years related to lung cancer. We had a peer-reviewed publication, and we have several manuscripts in the works. And I have been able to use Raymond's idea. This is a collaborative approach from 2018 that we've been working together, and I was able to secure AI fellowship, which I'm finishing, and that and it's gratifying to see everything come together. Thank you. Happy to take any questions.
Dr. Nara, you've completed your AI fellowship?
July 31st, they said. I thought it was August, but they said, yeah, July 31st.
Congratulations.
Wonderful.
I am impressed with that, with the presentation, because I think about my sister who was healthy, going to the doctor, and then she called me and said, I have a little nodule and they biopsy, and I'm in stage 4. Within 90 days, she was gone. So I'm very impressed with what I hear.
Thank y'all so much for that presentation. And, you know, the new wave of cancer treatment is going to be early detection.
Yes.
We have obviously great ways to treat now, but how can we get it detected earlier and earlier? And I think y'all are right at the forefront, so we appreciate everything you're doing for our patients. Yeah.
We got to get more Dr. Patels in the area that are doing this procedure, because even being able to identify, you're going to have that
I'll
kind
send
of
you some
follow-up.
patients.
Yes, please. Please, clinical trials, please.
Yeah.
We have clinical trials at JPS, so please.
Absolutely.
Yeah.
Great work, you guys. Thank you so much.
Thank you.
Thank you. Thank you all so much. We'll move on to the 2025 quality priorities. This is where we bring updates to the board regarding some of the priorities that were identified for 2025. The first is the Africa program. This is also the quality AIP goal, and as you will recall, is a program that has 6 measures: cesarean section, post-operative sepsis, planned all-cause readmission, food insecurity, and immunization with safe use of opioids. We are doing very well on 4 of the 6 measures. As you'll see, there's still a lot of work ongoing with our cesarean section, as well as hospital readmission. And as we have brought forth to this committee in the past, the readmission, the way the state defined it, is actually very, very difficult, and they've gotten a lot of feedback from virtually all hospitals participating in Africa. There's another meeting that they have called in August that they invited all of us to yesterday, and we'll be there to provide additional feedback on this measure. This is our quality dashboard to show the breadth and direction of a lot of the other quality measures as an organization that we collect, follow, monitor. We are doing well on most of them. A lot of it is really some of the ones that are dependent on volume of patients that we are seeing. We will see a slight uptake, like the minutes to decision time in ED. You'll see an uptake in that. That has really been driven by volume. On some of the other specifics, I'll provide some deep dive in subsequent slides. Today, I'm bringing before you 9 committees, programs, and departments that have presented to the Network Quality Council as part of our quality assurance and performance improvement process. In May, we had patient experience, respiratory care and supply chain, and OR operation, behavioral health, and glucose management and critical care presented in June, then infection prevention and community health quality in July. Patient experience first. As you all are aware, 2025 is the year of the patient, and we really believe patient experience is quality. Our patients do have a lot of say in what quality care looks like, and that has really been what has been the commitment and what's been going on across JPS. Every single provider quality scorecard is carrying patient experience as a measure. And patient experience also ties in with grievance. How do we address when our patient have any concerns so we can perform some service recovery? This is a scorecard that we bring also frequently to this committee for your awareness. We are doing quite well. We have our patient experience team led by George French and has been doing an amazing on-ground work with individual providers, nurses, and every staff to ensure that we continue to see consistent improvement in our numbers. And all of these numbers track down to individual provider level. He did share some of those data with me on a regular basis, and including today, to actually demonstrate that all of the interventions that he's been putting in place with his team is actually impacting these numbers. We continue to go up on our FY to date number, our overall rating, at a rate of about 0.1% every week, which is really very remarkable and a testament to the amount of work that our patient experience teams are doing.
I remember the look on the face when you said, oh, 80%. I remember that look I got.
We still are talking about that, Dorothy.
Maybe you can hang out in the ER and be like, come on, guys. Come on, patients.
Come on, patients.
The next department is respiratory care. This is a department that's actually come before you multiple times with their quality measures, and they did present again to keep us, to get us updated. And as you'll recall, they are in both inpatient and outpatient service, and they assist with our ventilator management, pulmonary function testing, as well as arterial blood gas in the ICUs. In terms of their turnaround time for arterial blood gas, they continue to do quite well. However, looking at their data, they are still seeing some significant outliers, which they have analyzed and attributed to new staff, and they are strengthening their protocol to include more training and audit, especially of the new staff, to ensure that this outlier time they are seeing is no longer an issue. Unplanned extubation per 100 device days, this number continues to go down, but this is one of those measures that we just have to keep a close eye on, but are not unexpected. If we're gonna reduce sedation and pain medication at the time of extubation, people wake up and sometimes get agitated and the tube could get dislodged that way. But this is well below the national benchmark. The average days on ventilator, this is really probably the most impressive number. And as an ICU doctor, I remember several years ago when we started tracking this number, we're around 4 or 5 days. And consistently, we have improved the number of days we keep in patient on ventilator by following all of the established protocol and also using more of the non-invasive ventilatory support. On the outpatient side, they're actually doing very well. Pulmonary function test, days to third next appointment is 7 days, which is really good, considering that in most instances, a lot of patients can get their pulmonary function test done the same day, if needed, at the time of encounter. Supply chain, well, it's very apparent that supply chain is quality, because if we do not have equipment to work with, then quality will suffer if they are back ordered. And they came by to present and shared a lot of exciting development that's going on with supply chain. Our VP of supply chain, Charlie Cobb, is actually doing a lot of metrics development in terms of contracts, KPIs, cycle time, fill rates, call downs, that we will be bringing back to this committee once those are developed, because this will really give us a very good line of sight regarding to what's going on with supply chain. And this is a metric that you've probably seen in other meetings, the supply cost per APD. This is really a volume normalized baseline for monitoring trends and spending trends and peer comparison benchmarking. We continue to do very well on those measures.
What impacts us the most? I mean, I know obviously supplies are expensive, right? But how do you drive down the supply cost? How can you be efficient in that?
I think Charlie said it best, and in listening to his presentation, the first thing is to really have a good line of sight on where all of the spend is going, all of the contract, understand that, and create a framework of, okay, this is how much we are spending. Then on the supply side, where is what's going, and how are we monitoring that, and how do we develop a real-time awareness, and what is our burn rate with each of those items? I think therein lies a whole lot of opportunities, which is why he's actually working on a lot of those metrics to give us a direct line of sight. All of these committees come back to the Network Quality Council every 6 months. So we expect that by the time you'll be bringing back the data, based on all of the work that are ongoing, we should be able to provide a whole lot more specifics around your question. Operating room. The most significant thing to know about the current operating room or operation is volumes. They've been seeing record-breaking volumes, and it was really very impressive. Again, we brought their report to this committee in the past, and you can see clearly there is a significant upward trend in the number of cases that have been seen per month. And the impressive thing about the team, which really a whole lot of credit to them, is quality have not suffered. Rather, there's actually been demonstrable improvement compared to the data we brought to you the last time we presented. The on-time starts in the OR is significantly improved from the last time. I will point out the target is greater than 66%, but we're achieving well above target at 70%. There are other variables like patient factors that impact that number. But on what is controllable, they've done a fantastic job improving that number. The OR turnover time is also significantly improved at 27 minutes, and OR utilization. Cell saver utilization is another very efficient in ensuring that any blood loss is actually clean and retransfused back to the patient. And this was highlighted as part of our certification process. We joined commission for blood product. I think we brought that presentation to you as well as having best practice as an organization. Flash sterilization significantly improved as well from the last time we brought it here, at 0.32%. Now, there's a lot of ongoing work regarding the OR refresh that is scheduled to start September 1. There's a lot of monitoring of all of our quality measure, high volume, and need to refresh the OR for about 3 months. Our CMO is leading that drive for this refresh in a multidisciplinary fashion in collaboration with the OR operation team and leadership of the surgical services and peri-op. And we'll continue close monitoring of these metrics, and especially during that transition period. Critical Care Committee also presented, and their numbers were quite impressive. Cardiac collapse, we are doing very well. And critical care at JPS is not just the ICU, it's also our progressive care units, that's E3, P4, and P5, and the number demonstrates a significant improvement. Clearly, I do recognize on a lot of these measures, pressure injury fall, the only acceptable number is 0, and that remains our goal. We are not satisfied with 21, we are not satisfied with 83, even though it represents a clear improvement, and we'll continue to work on those to ensure that every single provider with our daily safety bundle will have an opportunity to review all of the measures that determines or predict pressure injury and falls every day on every patient during round. Restraint is another one that we look at very, very closely, and that is also included in our daily safety bundle, especially in critical care settings. Meals compliance is our modified early warning system. This is what tells us way ahead of time, several hours before a patient deteriorates, that this patient is not looking good, they need attention, you better do something. If you don't, something is going to happen. And the compliance is very good. We are working on another system with our IT colleague that EPIC is just rolling out, deterioration index. Looking at our organization data, they were able to tell us that it actually performs better, but we want an updated data, and we're in discussion with senior leadership across the organization and nursing, both physician, nursing, and other staff to ensure that we actually deploy this well. This requires less input, but it's a better tool than meals. So we hope this will help improve early identification of patients that are getting sick so that they can be moved to a higher level of care or appropriate intervention is deployed for those patients. Behavioral health also presented their quality measures. They had quite a number of inpatient quality bundles, all of which are meeting target, including tobacco, alcohol, substance use, and transition record. Also, their throughput, inpatient throughput bundle is meeting all of their target, and it includes length of stay in the psych emergency center, average number of days for referral in work queue, time from admit to inpatient arrival. The areas that they presented some challenges is restraint and seclusion hours per 1,000 days. But this, when they actually did a very deep dive, they deep dived into their data, and they had one patient responsible for 50% of the seclusion time. And they had 3 patients for 50% of the restraint time, and they see huge volumes. Nobody even comes close to the number of volumes they see in the whole of Tarrant County. They have created a system that everybody agreed during their presentation that is quite impressive. If after 2 events of requiring seclusion or restraint, there has to be a team huddle, right, to deal with this increased frequency. And a medical review is mandatory after 3 events. And also there is leadership escalation for multidisciplinary review if this becomes a persistent issue in a single patient, to ensure that we have a lot of eyes looking at the same patient and our circumstances, and to resolve any issues that could be triggering the restraint as well as seclusion requirement. Inpatient diabetes program. Diabetes, looking at JPS data, diabetes is the second comorbidities that our patient presented with, and it carries a lot of, it's a risk factor for a lot of disease, chronic kidney disease, stroke, heart failure. So we do have inpatient diabetes program that really reviews and provides the organization with advice and implementation plan of diabetics control when patients are in the hospital. A lot of these patients are surgical patients, and poor control of diabetes can lead to delayed wound healing, which is why this program is very important. There are 2 metrics that are actually CMS metrics that will be fully required by all organizations to submit to CMS by 2026, hence the lack of a national benchmark. This is the first year. Next year will be the first year that all organizations across the country will submit to CMS. Our team has been ahead of the curve, really helping us in terms of achieving on all of this measure. And they've built various protocols in a multidisciplinary fashion to ensure that we are ready. The 20% number looks high, but looking at the data, the average nationwide based on journal review is about 22 to 30%. Because a patient comes in, they have a blood glucose of 200, you get highlighted. Somebody is getting dextrose infusion, and somebody mistakenly checks a blood glucose around that area. These are all electronic quality measures. We cannot say, no, that's an error. It gets reported as a ding. So it's one of those areas we're actually keeping a close eye on, and this measure is going to help us get there. Community health, and as you all know, overwhelming majority of patients that have any interaction with JPS is through community health. One of the feedback we've gotten from Dr. Duncan is to increase our focus on community health. So we have worked with our community health counterpart to develop community health quality, and it's still a work in progress, and we're developing a dashboard for community health that will really increase our focus on community health, and we'll be using that to drive improvements. So this dashboard is not ready. Only the first and second part are ready, but we'll be bringing it back once it's completed by IT. There's a lot of work going on with it. And some of the measures that they are tracking includes procedure timeout, compliance, 96%. We believe some of the 4% is related to documentation practices and our ability to capture. The only number acceptable there, again, is 100%. We'll be doing that. Specialty referral, the number is a skewed data because it takes into consideration all specialties, including dermatology, urology, that we know access is an issue. But when looked at individually, cardiology, pulmonology, the numbers are actually much better. But there's a lot of team working on that as well. Critical value documentation is another one to ensure that if we have critical values, we're able to document appropriately and notify as appropriate. Again, we're aiming for 100% on that. Infection Prevention Committee also presented. This is a multidisciplinary committee of nursing, physician, quality lab, EVS, and the goal is to reduce healthcare-associated infection and to respond to any outbreaks across the organization and help, most importantly, watch our isolation practices, hand hygiene, and EVS cleaning. One of the measures they monitor regularly is CARDI, catheter-associated UTI. We have done remarkably well with this measure, and it's because of the work of this committee, and on many months we're at 0 or 1, and it's really because of all of the work that's been hardwired in place. Our SIR is currently 0.44. The last time we presented, we were doing well, but we're at 0.56, so significant improvement from prior. We are doing well with central line-associated bloodstream infection, but our trend is not the direction that we want to see. We are still below what is expected. Most of this has been driven by a single patient that was in the hospital for a very prolonged period with a lot of medical challenges that required prolonged TPN for over a year. So a lot of those we brought before NHSN to really review with us, and most likely our expectation is that they will actually pull those cases back as not hitting our BSI. But in the interim, we had to report it. Colon SSI is another success story, significant improvement from prior. We are doing much better, and we do have an SSI work group that look at this data and every single case of colon SSI to ensure that we address all of the fallouts proactively with subsequent cases. C. difficile, we are doing well, and 0.18. We did have a spike around this time last year, but it was not just JPS. It appeared another strain. There was an outbreak of another strain across Tarrant County, but we have since recovered by intensifying all of our prevention practices. Next is the accreditation update. As you probably may be aware, earlier this month, the Joint Commission and CMS, actually later last year, came up with some updates to the way they will be doing accreditation and surveys and their condition of participation, focusing primarily on maternal care. And it will become effective, the phase one is really become effective, that they're expecting all hospitals participating in CMS to have emergency service readiness, transfer protocols, and training, especially as it relates to maternal patients, because quite often they present in emergency setting and they will need to be transferred to OB settings. We already have this established at JPS and it's fully functional. And they also require annual staff training to include emergency department, nurses, provider, and tech, so that they will be aware of all of this. We already have this as well at JPS, and everybody is aware, and we will continue doing those annual staff training. The phase two will go into place in 2026 January to look at our women's OB or obstetrics organization staff and provision and protocol. We just went through an MLOC survey, and that was brought before the board as well, and we have all of this, and our team is ahead of the curve in most of the requirements, but we felt we should let you know since TJC is bringing out a new recommendation, and especially also they require, especially for the phase one, board should be aware of these changes, hence the need to bring it before the board. And training OB staff and OB QAPI activities and network integration. OB QAPI reports to network QAPI. We are very well integrated, and we bring their data to you, and they also come before the board to bring their data as well. So we do have some integration, and we are meeting all of this, but we needed to bring this here for your awareness. Joint Commission also on June 30th released some updates to the way they'll be doing survey. A lot of their updates focused on reducing the number of elements of performance that they'll be requiring from around over 700, they cut it by half to around 316. But really, if one looks at it closely, it's really a roll-up of a lot of the measure and consolidation. But they did do a lot of work in terms of clarifying the language better and making it more user-friendly. And another thing they did I thought was actually quite smart was to say, we're not only going to come to your organization to highlight your deficiencies, we also want to come to highlight things that you are doing very well. Hence the safer peer benchmarking, hence the safest report rather. They will come and evaluate our strength as well and provide a report on that and share that with that other organization as best practices that they could learn from each other. The third thing they are doing is also a benchmarking tool, a benchmarking dashboard, which means after their survey, they will publish it and give us an idea of where we stand compared to other organizations. So they are saying it's no longer sufficient to say we've been surveyed and we're okay, but how do we stand when compared to other organizations? So they will be giving us those data, and all of these are effective in January 2026. Another update that they made, even though without a lot of fanfare, is they will be collaborating with Palantir, which is an AI company, to be looking at all of our electronic quality measures and the metadata that comes with that to really give them a better understanding of where the issues are in the hospital. So any time they are probably coming next time, they will be aware of some issues we are not aware of, just based off of our based off of the data electronically that they will be getting, given this collaboration.
Do you think that like the quality dashboards will be part of that, or do you think it's just Epic data?
So what they do for several years now, TJC has been requiring us to submit data to ORIX, and they only take electronically. So those data like cesarean section, perinatal morbidity, severe maternal morbidity, CLABSI, CARDI, they get all of those data. And they're able to analyze, because those data, in addition to saying, okay, this is the data contained, you are doing well with this measure, it also says, oh, patient appear to have arrived at this time because there's a timestamp in the ED. They went to the cath lab by this time. They got to the wards by this time. So they will have those ideas. So we may be achieving, but they will say, they may come up and say, hypothetically, between your ED and cath lab, there appears to be some delay. Let's do some deep dive there. So we ourselves, to your point, will need to be aware of all of this data at the next go-round for TJC, because again, it's not sufficient for us to be doing well. We have to know why we're doing well and if there's any other focus or area of improvement that we need to work.
Can't hide anything.
You can't do anything.
So we do have two policies for your approval, and we bring this to you every year, and this year is coming at the right time so that it will be approved and ready to roll out October 1st, the beginning of the FY. It's a QAPI plan and the quality priorities for FY22. We really have seen, and there's widespread understanding and support that patient experience is quality, and would like that to remain a focus of what we'll be doing for FY26 as well. Develop disease-specific quality metrics based on community practice. This is actually one that I'm very, very excited about. I wish I could claim credit for it, but I can't because Dr. Duncan is sitting right there. She actually challenged us and said, we come to her with a lot of CMS-related quality measures, state acts or mandated quality measures. How can we demonstrate that we're actually living up to our mission that says transforming healthcare for the community we serve? How are we using disease prevalence in our community to actually drive quality? Are we analyzing our community-based data in terms of the disease prevalence in different clinics on the outlying side, and are we developing metrics based on that? We've started a lot of work on that, and we're learning a lot. I am. So going beyond the traditional CODI, CLABSI, PSI 90, very, very important. It's also important to look at our community data and be able to speak to that and offer those data back to each of those clinics. If you want to for example, if the prevailing diagnosis in Southeast Medical Home is hypertension, we want to do outreach on a lot of things, but we want to make sure hypertension is also a focus for that clinic and that all of our providers in that clinic are aware. Another example is lung cancer. Which zip code, for example, has the most lung cancer in our area? We really need to be able to know that and collaborate with our outreach team to be able to educate to those. And really, which was what I was referencing earlier, that we will have benchmarks that will actually help us define and capture success. How can we demonstrate that the effect of our intervention is actually successful? And we believe that is quality as well on behalf of our community. Readmission rate is also one that we want to continue. And all of our healthcare-associated infection, we want to continue with those as well. Maternal health is a big one, both for CMS, for this organization and the state. It's part of Africa program, a lot of quality measures. Maternal health is one that we also intend to continue to focus on. And we'll be adding any other measure as determined by any other organization priorities, board directives, as well as AIP goals. This is our QAPI plan, the workflow, and this was approved by you. We have not made any changes in it. It's working very, very well. The Joint Commission gave us a very good feedback on this as one of the best they have seen and as best and representing best practice. And I think in the folder, the QAPI plan is there, and there's a red line version of the QAPI plan.
Arrows now go in the right direction. Okay.
Yes, sir. The 871, yes, sir. Yes, supposed to be greater than 200. So I think there is the 300 component of it, but the one that is reportable to CMS is 200, but I'll definitely double check. 300. I will double check that. Thank you very much.
Yeah, you need it.
The QAPI plan.
Does anybody have any questions over the QAPI plan before I make a motion to approve the updated? Anybody have any questions? No? Okay. Can I make a motion to approve the updated fiscal year 26 QAPI plan with its changes? So we have a move for approval by Dorothy and a second by DT. So we will approve. All in favor? Any opposed? Okay. So it is approved. And there's one more thing for approval.
Yes. The second policy is the infection control, infection prevention and control, IC1. This is also, this is required by both CMS and TJC as well. It speaks to the plan we have for infection control and discussed also the staffing. The staffing for our infection control and the work of the infection control committee. There's been no significant change in that as well, and the red line version is also in the packet. It's just really a change in the year.
This meeting is being recorded and summarized.
Thank you. Does anybody have any question about the infection prevention and control program? Can I make a motion to approve? So all in favor?
Aye.
Any opposed? So we will approve the updated infection prevention and control program. Yes. Okay, I think you can serve. You can be, you can second even though you're not on the committee. I appreciate you joining us. Second. Okay, perfect. We have committee members who have approved as well. I think that, is there anything else in the open?
No.
So, okay, well, we will then close the open session and we will resume in about 5 minutes for the closed session. Because Dorothy insists. Do we have DME? Does JPS have its own DME? So, thank you all for coming today. And
Thank you.
we'll see you at the next Quality and Improvement, Quality and Patient Safety Committee meeting.